All right, talking about abnormal psychology or psychological disorders, and I think this is what most people think about when they think about psychology. So I think one of the first things you have to look at is what do we define as normal versus abnormal behavior. And usually the way I like to think about that is with the acronym UMAD, behavior that is unjustifiable, maladaptive, atypical, or disturbing are things that we classify as abnormal behavior. So something that may be unjustifiable is if you put a bone through your ear or your nose. Why are you doing that, and how do you justify that behavior like if it's not part of your culture? Maladaptive is doing things that hurt you, but you still do them. So like smoking is somewhat of an abnormal behavior because we have enough research. We know that smoking is not good for you. And addiction is an abnormal behavior. So people who are addicted to nicotine, that's a maladaptive behavior. Atypical would be like maybe a genius level or maybe on the opposite end of the spectrum as well. So it's that atypical type of things. And then disturbing are doing things like hurting animals, setting fires to things that don't need to be set to, murdering somebody. Those are all also signs of abnormal behavior. So mental health workers view psychological disorders as persistently harmful thoughts, feelings, actions. Behavior needs to be deviant, distressful, and dysfunctional for psychiatrists and psychologists to label it as disordered. So deviant behavior is something that kind of varies sometimes by culture because, for example, you see in that picture over there, it may be perfectly normal for men to wear costumes to attract women. I'm not sure if men in this country wore costumes, how attractive they would be to people or to women. Also things like going naked in one culture may be okay, and here it may get you arrested. Deviant behavior must accompany also distress. It must be distressful. And then if a behavior is dysfunctional, it's clearly a disorder. So early theories, we thought that abnormal behavior was the evil spirits trying to get out. Trephining was often used, which was kind of like going in to try to get rid of those harmful disorders. You see right there, lobotomies were very common. Ancient treatments of psychological disorders include things like exorcism, being caged like animals, being beaten, burned, castrated, mutilated, transfused with animal blood. They believe that if you bore holes in the skull, you could remove evil forces. Because again, anything that was like this abnormal behavior were evil spirits trying to get out. So the idea is that you would do a lot of different things to try to release those evil spirits. Here you have the idea of the perspectives that we've talked about and then where they feel like the cause of the disorder is. So psychoanalytic, psychodynamic, obviously is Freud, that internal unconscious drive. Humanistic psychologists feel like it's the failure to strive to one's potential or being out of touch with one's feelings, because that's like Maslow, Carl Rogers, their hierarchy. Behavioral reinforcement history, the environment, the idea that it would be about what you surrounded yourself with and your family. Cognitive, just that it's irrational, dysfunctional thoughts, ways of thinking. Sociocultural is that society is dysfunctional and that's the problem. And then you have biomedical neuroscience, where it's organic problems, biochemical imbalances, genetic predispositions to a psychological disorder or abnormal behavior. The medical perspective, you have Pinel from France. He insisted that madness was not due to demonic possession, but to an ailment of the mind. And so he was really the first person that said it wasn't because of evil spirits. And you can see down there, it's a dance, and they used to call it the madhouse. When physicians discovered that syphilis led to mental disorders, they started using medical models to review the physical causes of this disorder. So etiology, cause and development of the disorder, then you have the diagnosis, identifying symptoms and distinguishing one disease from another. treating a disorder in a psychiatric hospital, and then prognosis. And those kind of go along with like what the 4 goals of psychologists are. They want to find out the cause, they want to know what's the symptoms, they want to treat it, and they want to know like what am I going to do to get better. So you can see here the biopsychosocial perspective, assumes that biological, sociocultural, and psychological factors kind of combine to produce these disorders. So it's biological, psychology, and then sociocultural influences that are all infusing and in these disorders. You need to be familiar with, and we'll look more at it in class, but the DSM is the Diagnostic and Statistical Manual of Mental Disorders. For us, the most recent version is actually the 6th version, but the AP Psych test hasn't quite caught up yet, so we just are looking really at the 5th. It describes 400 psychological disorders. It started in 1950s and only had about 60, and some of those disorders have changed over time. For example, like homosexuality used to be defined as a psychological disorder, and it's not anymore. So the Diagnostic Statistical Manual of Mental Disorders, or it's like a big book of disorders, and it classifies the disorders, it describes the symptoms. It's not going to explain the causes or possible cures. So it really is just to classify disorders and describe those symptoms, and we'll look at it in class. And also there's a link posted in Edmodo if you're interested in taking a look at it that you can go to. The 2 major classifications in the DSM that we're interested in are neurotic disorders, distressing, but one can still function in society and act rationally. And then you have psychotic disorders where a person loses contact with reality, experiences are distorted, perceptions. So neurotic disorders, you can still function in society. So things like anxiety issues, that kind of thing would probably fall under neurotic disorders. And then you have psychotic disorders where you totally lose contact with reality. So here is how they classify things in the DSM. You need to make sure that you know this. So an Axis 1 is a clinical syndrome. Cognitive, anxiety, mood disorders. There's 16 syndromes. Are they present? And we'll work with this some in class too. Axis 2 is a personality disorder or mental retardation present. Axis 3 is it a general medical condition. So diabetes, hypertension, arthritis, is that also present? Axis 4 are psychosocial or environmental problems, school or housing issues. Are those also present? And then Axis 5 is the global assessment of this person's functioning, like looking at them holistically. The goals of the DSM are to describe the 400 disorders, determine how prevalent the disorder is. Disorders outlined by the DSM are reliable, therefore diagnoses by different professionals are similar. So that's a good thing, is that it gives some structure to psychological disorders. Others criticize the DSM for putting any kind of behavior within the compass of psychiatry, because I promise you, when you check out the DSM, some of you may flip through it and be like, yep, check, I do that, check, and then you could classify yourself as having a psychological disorder. Some of you may, but others of you may not, because the idea is that it kind of umbrellas a lot of those disorders. So that's just kind of a criticism of it. Labeling psychological disorders. Critics of the DSM argue that labels can kind of sometimes stigmatize individuals. You see down there, there was an asylum baseball team. So we don't want to label people. Labels may be helpful for healthcare professionals when communicating with one another and establishing therapy, but when those labels become part of our common discussion and our common language, that I think becomes a problem, because we are not necessarily healthcare professionals. So like insanity labels raise moral and ethical questions about how society should treat people who have disorders and have committed crimes. So you've got anxiety disorders, which is a large group of conditions where the primary symptoms are just anxiety or defenses against anxiety. The patient fears something awful will happen to them. They're in a state of intense apprehension, uneasy, uncertainty, or fear. You have phobias. A person experiences sudden episodes of intense dread. They must be in an irrational fear. So, like, I mean, something that's not going to hurt you. I'll show you this phobia list in class, but I know my mom has a severe fear of, like, elevators. And it's pretty irrational because most people ride elevators, it's fine. But, like, closing spaces, things like that can be classified as a phobia. You can also have a fear of pickles. Those are a phobia is an anxiety disorder, and you also have what's called GAD, which is a generalized anxiety disorder. It's which you're just continuously tense, you're apprehensive, you're in a state of autonomic nervous system is constantly aroused. You feel worried, you feel inadequate, you're oversensitive, you can't concentrate, you can't sleep. It's just this general level of anxiety that you have all the time. Panic disorder is also an anxiety disorder. It's marked by minute-long episodes of intense dread in which a person experiences terror, accompanying chest pain, choking, other frightening sensations. A lot of times, like you can't get your breath, you can't breathe, but you just have this long, intense period of anxiety that goes on and on and on, where you just feel like your chest is tightening up and you're afraid. And you have OCD, which is persistent, unwanted thoughts, obsessions, cause someone to feel the need, compulsion to engage in a particular action. So washing your hands repeatedly, obsession about dirt and germs may lead to compulsive hand washing. A lot of times it starts off with things like you have to, open and shut the door like 4 times. Like there's a need to do that. So you can see right here the persistence of unwanted thoughts, urges to engage in senseless rituals that cause distress. Obsessions, you can see 40% of the people have an obsession with dirt, germs, or toxins, which leads to excessive hand washing, bathing, toothbrushing, grooming themselves. Sometimes they will wash clothes and immediately will feel the need to take those off and rewash them. Something terrible happening, fire, death, illness, which leads to things like repeating rituals, checking doors, locks, appliances, car brakes, homework. Also symmetry, order, exactness, that you need everything in an exact way. All signs and symptoms of OCD. You can see here brain imaging, a PET scan, which is a brain, you'll activate it when they ask you to do something, and it shows up is a scan of the brain right here. The high metabolic activity, the red in the frontal lobe areas, are involved with directing attention. So you can kind of see that those brain images of an OCD person kind of light up whenever they have those obsessions, those compulsions. And then you have post-traumatic stress disorder. It's 4 more weeks of the following symptoms: haunting memories, nightmares, social withdrawal, jumpy anxiety, sleep problems. We obviously, most of the time, we associate it with people coming back from war zones or military activity, but it's 4 more weeks of those types of symptoms. Again, all of these are anxiety disorders. About 10% of women and 20% of men react to traumatic situations and develop PTSD. Holocaust survivors show remarkable resilience against traumatic situations. All major religions of the world suggest that surviving a trauma leads to the growth of an individual. So it's something interesting to think about, that religions and other studies have shown that surviving a traumatic event leads to the growth of a person. But it's not without necessarily developing some habits. But that post-traumatic stress disorder, again, is the 4 weeks of the haunting memories, nightmares, social withdrawal, jumpy anxiety, and sleep problems. So everything we talked about today was the history of psychological disorders, and then also the end with anxiety disorders. So let me know if you have any questions, and we will talk more about this in class. Thanks.